over 20 years and has a very keen interest in the nutritional aspects of healthcare. He's been with us before, as I said, but this is his first appearance in person in the studio. So, Simon, it's great to have you with us. Welcome to our studio.
It's a pleasure to be in the flesh.
Yeah, it's great. You've been with us before, and
Yeah.
I've asked you this question before, I know, but so how do you, a chiropractor, get this interest in nutrition and in migraines, which is our topic for this evening, isn't it?
Yeah, so really through my own health issues. So I qualified in 2001, and from when I started college through those 5 years, in 96 to 2001, I was getting iller and iller. I just didn't quite know. I was having IBS and skin problems and brain fog and all sorts of other problems, and getting more and more stiff and achy. And
nowadays they just call it COVID.
COVID or fibromyalgia or something.
Yeah.
So in the end, in about sort of late 2007, I think it was, 2008, I got diagnosed with ankylosing spondylitis. Mm-hmm. And then a few years after that, I got psoriasis. And that then, I'd already had an interest in nutrition and so on at college, but it really then had, I had to do it for myself then at that point. And so I dug right down into functional medicine, nutrition, and I had some infections in play, and gluten intolerance, and a whole lot of other bits and pieces, some dental infections. And so through doing all of those bits and pieces, and having some dental surgery and gut treatment stuff, I was in remission from psoriasis and AS. And then once you have all that information, it's pretty dense stuff, and you have to be able to then try and, how did I want to translate that into my chiropractic practice, because still a chiropractor. And that was hard, because full-time functional medicine, nutrition, it's, you're there with the client for an hour, and then you got 10, 15 minutes or whatever it is, and you've got to do your chiropractic bit or your whatever you're doing, and integrating them is hard. And that's kind of been the bit what I've done more recently, was trying to distill down the bits that are really pertinent in what I would say is a neuromechanical setting, be it chiropractic, osteopathy, physiotherapy, whatever it is.
It's what I've enjoyed about our conversations in the past, that you're introducing things that lots of people can do without going on lengthy courses to learn about. Yeah. Although obviously you can provide them with that information if they need help, but stuff which can make a big difference to the outcomes for their patients, which I think is very, very helpful.
Yeah.
Just for clarity. If you were an osteopath, I could say, well, are you a cranial osteopath or a structural osteopath? What kind of chiropractor are you?
I am all of those. So I do a lot of manipulation. I do a lot of muscle testing. So I went off and did a muscle testing course when my first year of graduation. That was very informative. So for me, it's like a window into the nervous system. Yeah. It's a very, it's a very obvious before and after. And then also I did a lot of SOT, sacro-occipital technique, which leads to a lot of cranial work and visceral work. So that's what we would call craniosacral technique. Yeah, exactly, craniosacral, cranial osteopathy. So I do a lot of muscle testing and manipulation, but also I understand the craniodental mechanism, and we'll talk about that within migraine as well. That's really important, and dentition. I worked in a dental clinic, working alongside the dentist with people with things like trigeminal neuralgia and all sorts of other weird stuff.
As a chiropractor?
Yes, as a chiropractor. I was in-house with them. That was really interesting, and learned a lot there.
But your formative years were at the Anglo-European College, I
Yes, a qualified,
so you were diversified by training.
Yeah, exactly that. So I'm structural, and I don't know what the word you cranial.
Diversified, isn't it?
Diversified,
is what, I thought that's what chiropractors call structural stuff.
It's a technique. Diversified is the kind of main technique. So I do manipulation, a bit of craniosacral or cranial technique at least, and then then I'm integrating in that the nutritional bits, and the bits I'm really interested in for my practice, and then what we teach in the course is what we would call keystone nutrients. So if you go to a functional medicine seminar, it's like a maze without a map, and you're going to get lost. So what you really want is, if the nutrient is low, that will be a showstopper. It will be if without that in place, that keystone, the system will not run. So vitamin D is the most obvious one, or vitamin B12.
We did a show on
or B12 as well. If you're low in either of those things, you are screwed. You will never be healthy. It doesn't matter what you do, they are not going to recover. They just will not. And so we want to know what those are, and then also they have to be able to replenish them relatively quickly, and usually with supplements or some kind of change, and see results within a few weeks to a month. And they're the bits we're interested in. If you do that, because the whole point, the patient has come in with something neuromechanical, I want my treatment to work. I have a whole lot of people where it works, just doing chiropractic and manipulation, soft tissue and stuff, and cranial works. And there's a whole group that the results tend to dwindle down, And a chunk of those is because of nutritional stuff.
Yeah.
If they can get the easy, low-hanging fruit picked, they'll respond as I would anticipate.
Do you know, I don't want to go down a rabbit hole of talking about vitamin D or B12 because we've done shows on those before. We did vitamin D with you, we did vitamin B12 with Tracy Whitty. Both of those shows are in our recordings archive, so people can look them up. But I must say that one of the things I found most difficult to get to grips with, particularly with B12, is accurate testing for vitamin levels, and then what kind of thing do you use to supplement? Because it's not simply a question of going to Holland and Barrett's and getting a B12 pill and taking it, is it?
I can summarise that if you want, because I do a B12 lecture. The simple answer is, and this is according to, this is the one time I agree with NHS guidance, is that the blood test is simply not reliable. Blood testing can rule in deficiency, but it simply cannot rule it out because often people with the what looks like really high levels is because they can't get B12 into the cell, so it's floating around in the blood and they can't get it into the cell. Or if they have pernicious anemia, which is autoimmunity against the stomach, the antibodies against the stomach lining look to the machine like B12 and it pushes the numbers up artificially. So the most important thing is clinical symptoms. Do they have persistent tingling, pain, numbness, particularly bilaterally? Do they have chronic fatigue? Do they have persistent pain? Do they have mental health issues? If you've got a trio of those, pain, brain, and fatigue, and you have a B12 level that is in intermediate zone, maybe under 500, or if they've got really bad symptoms, you always should give a trial of B12. And that's what it says in the guidance, actually. It's routinely ignored. You should always give a B12 trial. And in our scenario, that would mean a sublingual. And usually in the active form would be most commonly prescribed. Just tuck it between the cheek and the gum, and I would co-prescribe with a methylating B complex, which will have folate, B6, some trimethylglycine and some B2 in there as well, because if they're low in B12, the chances are they're low in other stuff as well. And you need to complement so that the methylation cycle, which we're going to talk about in a minute actually, spins and they feel better. And there's no risk in terms, there's no toxicity for B12 or anything at all.
Yeah, that was the lovely thing about talking about to so many people about vitamin supplementation, which of course is of no interest to the pharmacological companies because there's no money in it. But it's very hard to overdose in any significant way, isn't it? You might get some diarrhea or something, but it's hard with most of them to overdose.
We should distinguish between water soluble and fat soluble. So water soluble meaning vitamin B, vitamin C, this comes in and it's out quite quick. Vitamin C might give you diarrhea. But the fat soluble ones, vitamin A, D, E and K, they will build up in your body, so they can be overdosed. So vitamin A toxicity is a thing if you took it long enough. And same with vitamin D if you went berserk. So
well, that's what I mean. You'd have to see.
You'd have to go at it.
For it.
Yeah, you really would. Yeah, and even you might be very unlucky with certain patients with unusual reactions. But yeah, for the most part, yeah, you'd have to really go at it for long periods to do any kind of damage. So
the bottom line is, people should look at your last broadcast for vitamin D. Tracy Whitty's for B12.
Yes.
What's the other one we did with you?
We did neuroinflammation, which we'll cover here again, in the context of the biopsychosocial model.
Yes, yeah. So there's some really good stuff for people to look into to back up what we're going to talk about today. But we're going to talk about migraines.
Yes.
So you had migraines yourself, you said?
No.
You didn't?
Never had a migraine.
Excellent.
But if you're interested and you want to know what migraine feels a bit like, then you could go and eat an ice cream and give yourself an ice cream headache, because that is a similar feeling. The cold comes up and it cools the cribriform plate very suddenly, and your body must try and warm that air up. And it does that by suddenly enlarging the blood vessels in the area, and you get a sudden stretch, and the blood vessels have nerves around them, and that hurts. And that's where you get that feeling of fullness and that pain in your head, and that is similar to what people get with migraine.
Not all migraines are the same though, are they?
No. Well, there is an umbrella, and in fact I would say there's a spectrum, which we'll have a diagram to talk about. So there's traditional, aura, with migraine with aura, which is the one people tend to think about, where you get flashing lights and also they know it's coming, and then they get the violent headache. And then there's without aura, it's still a migraine, but they don't quite get some of the prodromal features. And there is some interesting research we'll talk about, and in terms of picking what you're going to do with patients, because the ones with with aura often have a genetic component and higher rates of deficiencies that will respond better to supplementation, particularly for treating the mitochondria. And then as we go through the spectrum, which we'll talk about, there's different things and mechanical stuff that comes in.
Okay. What about those people who have the prodromal stuff, the aura, but don't get pain? I'm really personally interested in this because I'm one of them.
Don't get pain. Well, we'll talk again. There's a thing, things like cyclical vomiting syndrome. There's abdominal migraine. There's a theory that colic might even be a form of migraine. So all of it comes down to really about mitochondria for the most part, for true migraine, which we'll talk about in a minute. So it basically comes down to mitochondrial dysfunction, and you may get different manifestations, but fundamentally the core of it is dodgy mitochondria and inflammation in the brain.
Okay. So before you crack on, I'm going to bring in my one visual aid for the evening,
Yes.
which is the nice guidelines on headaches
Ah.
in the over 12s. Now, this is a riveting read. It's nail biting. You have to get to page 14 before it mentions migraines, and
Yeah.
page 17 before it mentions treatment. But other than standard pharmacological remedies, the only thing it recommends is a course of 10 sessions of acupuncture for
Right.
migraine with or without aura,
Right.
as being something you might try.
Okay.
I'm guessing you're going to suggest that there are other things we could do. Well, let's start
Yes.
with what do you think of the nice guidelines?
Yeah, they're all right. I mean, they are what they are. And so it's very pharmaceutical led. They want a certain level of evidence, and evidence in that context is really about randomized double-blinded studies. And then they want a certain methodological quality. And of course, these things are expensive to run and hard to do, and the drug companies have the money to do it with drugs. The supplement, who's going to fund that? Because
There's also a mindset, isn't there, in conventional medicine, which says this is a pain, we need a drug that will fix it.
Yeah.
And that's the way they are driven.
Yeah.
I have a particular reason for bringing in the nice guidelines, is that I think every time I can, I bring in the nice guidelines because it looks really good on the certificate that we've done it. People have got a reference document that they can talk about if they're having to refer someone to a GP or whatever else. So it enables enables people to talk about the conventional approach.
Yeah, I mean, it's very pharmaceutical, very symptom-led, and there's a slide later on at the end where we're talking about there's a drug they have for migraine, which is this sort of miracle drug they talk about. It's about $7,000 a year, and it gives about 50% reduction in migraine.
Right.
So what we want to know is, we know that in migraine, there's a lot of inflammation in your brain, and that inflammation, dysfunctional mitochondria, is damaging you. And that's one of the reasons you get migraine. And that underpins all neurodegenerative diseases, cancer, strokes, a whole load of stuff. So the question is, can we ethically just treat the migraine with a drug, which squashes it down in one area, but we leave all the root causes in place and all of the downstream effects? When we know, I've got lots of research coming up, we can reduce to that extent, and better in some cases, with supplements and diet manipulation. And it's very cheap.
Okay. Interestingly, we had a lady called Elizabeth Hussey on the program quite some time ago now. She was talking about headaches, and she mentioned the business of acupuncture being effective. And apparently, acupuncture is effective in, I think it was 75% of migraine cases, to some degree, and I can't remember the measure of improvement. But sham acupuncture was only 5% less.
Yes. And we'll see later on that there is, we'll talk about it in a minute, to do with the neck and the jaw and how that overlaps into true migraine, which migraine is a cellular event, but the question is why are your cells going bonkers?
Before we get on, and I want to get onto migraines, your stuff properly in a minute, Wallace says, do you use medical acupuncture as part of your management of migraine?
No.
No, okay, that's fair enough. And John says, which muscle testing course did you do, and how do you use it to treat or assess migraines, or will that come out as part of it?
No, it's not. I would tell you, I did Simon King's course, and it's now called Afferent Input. Okay. I think it's Afferent Input. If you type Simon King, Afferent Input, his stuff is it's genuinely unique, and some of the stuff he's developed, and there's stuff there that I use every single day regularly, and some of it is absolutely golden, and I would never be without it. He's very ethical in his approach to muscle testing. Some of muscle testing can be a little bit fluffy, frankly, and he's having none of it. So I would definitely recommend that. Right.
Simon King is a
chiropractor. He's not registered anymore as a chiropractor, but he is by training, he's a chiropractor.
Yeah, okay. So now we're getting into the meat of this. We've clearly got the buffins on tonight, because someone who the machine is calling green grass makes healthy sheep says, I thought migraine research suggested a sweeping wave of cortical neurotransmitter depression, or is this now out of date?
No, we're going to talk about that in a minute.
Okay, good. Right, over to you. Let's talk about migraine.
All right, so if we go through some slides. Hang on. There we go. So the question is, are we primed for migraine? Because some people get migraine at very easy, and some people do not. And there's definitely a genetic component, we know that for sure, or epigenetics, so we say around the gene. And the reason we're interested in that is because we know that there's a lot of deficiencies involved, and that we can get around some of the genetics by picking those deficiencies, or in some cases, saturating the tissue to make the enzyme work. So the genetics are a code for an enzyme, and that pushes the pathway. And if we can sometimes saturate the tissue with the nutrient that is activating the enzyme, you can get around some of that.
I always forget to say to people before we start these things that I know there are slides on the screen here, and I know you're getting them flashed up as we go through this. I will send them out as handouts after we finish the show. It's going to probably be tomorrow evening because I'm, as I say, on jury duty. So don't worry if you haven't had time to write it all down or something. The great thing here is just listen to what Simon has to say. So we're on deficiencies.
Yeah, so B vitamins, vitamin D, magnesium, CoQ10 and carnitine. They're the ones that I use the most often. Carnitine is a very underused nutrient. It is amazing, and we'll talk about that later. And the other thing is food reaction, and particularly as a food intolerance, and we'll talk about the difference between a food intolerance and then later on that there's certain food triggers that involve things like nitrites and sulfites, and they're a slightly different thing. But those things come together, and then they give us really dysfunctional mitochondria. So you've got to make energy, and so you're breaking the bonds of the food to release in the electron transport chain. You're always going to get a degree of leakage of electrons, and that manifests as a free radical, and that's going to create oxidative damage. And the problem there is that the more dysfunctional mitochondria are, the more damage you get. That damage creates inflammation. That inflammation creates more oxidative damage, which damages your mitochondria. And you get this really vicious cycle. I said this underpins Parkinson's, MS, Alzheimer's, all of it's underpinned by that. And indeed, most complex stuff, this will be involved somewhere along the line because we have to make energy and so on. So mitochondria is number one source of free radicals, followed by inflammation. And particularly we have what we'd say is a sustained low-grade inflammatory response, systemically in the blood, but also in the nervous system, because your blood-brain barrier is sensing the blood, so there's inflammation here. We could be under attack because the immunity is up, so we'll turn on our immune system in the brain, the microglia, and we will make a bit of inflammation to make sure we clear out any infection. But if the, quote, infection is in fact gluten or dairy, then it never goes away because you eat it every day, and then you have a sustained inflammatory response, which you shouldn't have.
And yet those people who are gluten or dairy intolerant are not always migraine sufferers.
No, because again, you might need to be genetically predisposed to migraine or have other factors with your jaw and neck that might combine.
This might be the wrong time to do this, but a quick question about mitochondria. We've just taken delivery of Cat4 laser in our clinic, and I remember when we were talking to Stephen Barabash, the guy who's the sort of marketing man for this in this country, who delivered it here, but he was also on the show before. He was saying that Cat4 laser is actually very, very good at providing energy or encouraging energy production in mitochondria. Is there a role for it, do you think, in what we're talking about this evening?
Yeah, possibly. I don't know about the actual brain itself. We have lasers in clinic we use, but so you might do it peripherally for some of the peripheral nerves in the neck, maybe into the jaw joint and those associated areas. I think that's how red light or lasers work in generally, is through mitochondrial stuff and cellular manipulation for sure. Yeah, so it might be useful. Yeah. Okay, so just as a reminder, I think most people probably aware, but just from a free radical, so normal stable electron should have pairs of electrons. Stable molecule, beg your pardon, should have a pair of electron. Free radical is unstable, has one unpaired electron, and then what happens is that unpaired electron, it nicks one from a neighboring molecule. So it's going in and that's damaging, and that then is a chain of events which gets passed down the line. It's like a fire that spreads and it just keeps going and going and going. If you don't have adequate antioxidants, which are molecules with a spare electron, they can hand over and neutralize that. And that's the issues that we have excess oxidation going on with a deficiency relatively of antioxidants.
If you have lots and lots of antioxidants, more than you've got free radicals, then you just end up with the same thing, don't you? Lots more molecules with extra electrons.
But they have a spare one.
Oh, right.
So they can hand it over.
Right.
So the other thing, we talked about this earlier about the idea of, can we treat symptoms and leave them? Migraines have, quote, comorbidities, a term I loathe, because All of these things, depression, anxiety, stroke, irritable bowel, fibromyalgia, all these things, they're all just symptoms, and they're all underpinned by the same things: inflammation, mitochondrial dysfunction, and so on. So they're really just symptoms of the same thing, and we want to look beyond that and really get at the root causes, because then you give the patient so much more value and so much better improvement in health.
On that last slide, it says that the information is derived from the American Migraine Foundation.
Yes.
Do they have a different approach to medical organisations in this country?
I don't think so, particularly. Right. I don't know, perfectly honest with you.
I was just curious.
I don't really do too much with the general associations and stuff, because they're just so pharmaceutically led.
Yes.
So migraine itself, the pain, is felt through the trigeminal nerve, and trigeminal is an unusual cranial nerve. So it supplies all of your face, and also your sinuses, but also it has a motor as part as well, so it supplies all of the muscles of mastication. And it also supplies your dura, which and all of the blood vessels have trigeminal innervation. So that's really important. We talk about the muscles of mastication, really important, those nerves. But then the other thing is that, as well as the trigeminal, where the trigeminal comes in at the brainstem, the upper three cervical nerve roots come in and form the trigeminal cervical nucleus. So it has a common input to the brain. So therefore, if you have something coming in, nociception from the upper three cervical roots, that will go in and it will stimulate the same nucleus. And this means you can get kind of a summation or a convergence of the two different inputs. And that provides us with a link from the neck, which then can potentially trigger a migraine, even if, yeah, so we'll talk about it in a minute, but it means that there's a convergence and an overlap.
The conventional world here certainly differentiates between migraine and cervicogenic headache.
Absolutely, yeah.
So this is effectively cervicogenic.
No. So what we'll talk about in a minute. So there's a slide coming. We talk about a mixed pattern. Okay. So they might get their normal headache, and they get here, and occasionally comes over the front, and then, but I get my once a month, you know, I get it goes into a full-blown migraine. And these people are definitely primed, but because of the cervical thing, and maybe their jaw, so then that's feeding in, and it's enough to push them over the edge. Right. So that C1 to 3 might be adding into the priming.
But it's not sufficient in its own right to cause a migraine.
Exactly.
Yeah, okay.
You need a combination of stuff and a priming of the system, and that's where we're going to look at. Oh, there you go. There's the migraine spectrum. So we have...
Just before you go on, because my list of questions is building here.
Okay.
Someone says, Simon says, an ice cream headache is nothing like a migraine. That's underestimating a migraine, exclamation mark. It's being unkind to migraine sufferers. Take it from someone who suffers from migraine.
I will go with whatever you say.
Yeah, you've obviously got it from people who have had migraines that theirs was similar, I guess, because...
I just know from... I read an article about migraine. They were just saying, if you want to know, roughly, it's the same. The enlargement of the vessels will give you a sniff of it.
One of the others, I mean, it's an early stage to ask this, but Claire's asked whether you know about the headache research which is going on within the osteopathic community at the moment. Yep. This is something that Liz Hussey's closely involved in, amongst others. But it'd be interesting. I'll share the resources with you later on.
That'd be great.
And then we've got some specifics about treating migraines, which I'll leave till a little bit later.
It might be coming up in the slides, yeah. So we'd say on the far left, we say true migraine. This is a cellular event, and someone mentioned this earlier. You basically have a very fragile central nervous system. So it's on the edge of depolarization. And what can happen is when you get to a certain point where you get a vicious cycle, you get what's called cellular metabolic collapse. And this leads to cortical spreading depression, which I think is what the person was saying there. It's a well-established thing that people get with traumatic brain injury and strokes and so on. So you get a complete depolarization of the brain. It goes like a wave, and it comes down through. And then at the end of it, then you have your trigeminal nerves wildly hypersensitive, and the aftermath is what we would call a migraine. Right? Everything is sensitive. You're really, you're getting hypersensitivity input of everything. Then at the far end, on the right, we really have a pure neuromechanical thing. So like you said, it could just be a neck pain, and it's a misdiagnosis. The patients are coming in saying, I have migraine, but they don't. They have a neck problem that's generating pain, and they just refer to it as a migraine because it's, a common term. Or they might have a jaw problem. and they might be having pain in their temple, which is the temporalis muscle, or jaw pain, or tooth that could be referring up, but they're just calling it a migraine. And that's purely a mechanical thing. Yeah. And that should be our, we should be all over. That's our bread and butter. And in the middle,
I'm going to show my ignorance and feel very embarrassed. Yes. What does NICO stand for?
I'll come to that. It stands for a nociceptive inducing cavitational osteonecrosis.
I'm not in the least bit embarrassed I asked that question.
So it's basically dead bone. I've got a slide coming. It's a dead bone in the jaw, which is causing pain, and they're wildly underdiagnosed. Very common in wisdom tooth sites, right, which I have. Then in the middle bit, we talk about that mixed pattern. So they have got a fragile nervous system, and it is prone to collapse. And some of that, as well as being deficiencies or toxins or food and inflammation, all the stuff we talked about, that trio of the mitochondrial stuff, because we know that the TMJ and the upper 3 cervical roots are pushing nociceptive input into the trigeminal cervinucleus, that will contribute to that fragile nervous system. So they might be getting a bit of both. They might have genuine, true migraine, but they also might be getting some local pain, and they have their, quote, normal headache, and then every now and again they get a proper migraine, and that you'll be able to mop up their local pain, and you'll improve their threshold for true migraine by improving the neck and the jaw, and that will then raise their threshold so they're less triggered by certain things that should trigger their migraine.
Yep.
That makes sense?
Yeah, makes perfect sense to me.
Great, okay. I think that middle bit, I think that's really important, because we'll have some people who come in who have true migraine, and you can do something mechanical and it's magic. And they obviously have a big percentage is coming from that input into the trigeminal cervinucleus. Yeah. And other times you'll do stuff and it does nothing, absolutely nothing, because they're a very pure chemical issue, cellular issue, and this has nothing to do with it.
And a lot of what we're talking about here comes down to definitions as well, isn't it? As you've said, if a patient comes in and says they've got migraine and it's either mixed or mechanical, and you manipulate the cervicals and it goes away, we think we can fix migraines, they think that they can get the migraine fixed, but actually maybe it's not up at this end of the spectrum. Probably.
Exactly so, yeah. So be very careful with what they're, when they say I've got migraine, you want to be very picky about what are your actual symptoms, because it's just it's a term which is well known.
How would you, if you're handling the patient, how would you sieve out the ones who haven't got true migraine? What are your questions like?
Oh, I mean, so with proper migraine, they know about it. They're flat out in a dark room often, with or without aura. You can't function, the ones that I've seen. When they're misdiagnosing, they'll often talk about, they'll get this pain in the temple here. They might refer to it as a tension type headache. That's almost always, it might be temporalis, and it's a jaw thing, and a bit of cranial work. And often they'll have mixed in is some upper cervical stuff as well. Often hypermobile in my experience. I don't tend to manipulate upper necks very often at all. So it's really about the severity often and the frequency. You don't get migraine every day. That's just not a thing. You wouldn't be able to cope with that. Not a true migraine, because it would just you'd be flattened the whole time. So frequently what they really mean is I get neck pain and it goes into my forehead, or I might feel it in my forehead or my eye or my temple, and that's what they're referring to as migraine. Okay, I'm going to skip on, if I can. There we go. So the primary mechanism, we said, is those three things: mitochondria, inflammation, oxidative damage, leading to this collapse of cells. And it's a wave. That's what people often mention, this wave-like thing that crashes over them. That's cortical spreading depression. And then the aftermath is the hypersensitivity of the trigeminal nerve, sensing the brain, and you get edema in the brain as the blood vessels become leaky and stuff.
So that probably was what our correspondent earlier on.
I'm sure it is. Yeah, I'm sure it is. Yeah, I'm sure.
But we had a quick question about this, if I may. Darren says it was mentioned that many neurological conditions are underpinned by mitochondrial dysfunction.
Yes.
But is this dysfunction a result of the GIT and inflammation there? And is this all a side effect of gut issues?
Well, it could be. Yeah, because we have a gut-brain axis for sure. People who have, neurodegenerative stuff. Like I had a patient with motor neuron disease I treated, and we did some organic acid testing, and he just had the perfect set of results for deficiencies and toxicities and mold toxins and Clostridium difficile and all this stuff. He was just textbook. So in his case, yeah, absolutely, you can't divide them up. It's all linked. The only thing again is, how do you break that vicious cycle? Where do we intervene to try and get in there? And often the easy way is with some supplements and then maybe removal of foods, because the results are quite quick. Yeah.
So you talked to that lovely chap in Scotland who does treatment for motor neurone disease, a chiropractor whose name...
Donald.
Donald. Yeah, Donald Francis, is it?
Yes, Don Francis, yeah.
We had him on the show. It was a virtual show, but he's what an inspiring bloke. He's another chiropractor, isn't he? And I think he's a McTimoney chiropractor.
He graduated from Palmer. Yeah, he does a lot of SOT cranial. He's involved in SOT Europe. Yeah.
Inspiring talk from him, and again, a lot of people who won't have seen the show might be instantly cynical about you can treat motor neurone disease. No, because you're not going to fix it.
No.
But my God, you can make people feel better.
Sure.
Which, I recommend. It's in our archive, so I'd recommend it to anybody who's interested.
Yeah. I think some of my favourite patients are not the people where you treat them and they get completely well and then they can come and go as they please. It's often the ones where they have been abandoned by the medical profession. And they have terrible quality of life, and some people are so unwell, you're never going to get completely well, but you really improve their quality of life, and they're so grateful, and it's so satisfying to be able to serve these people. I think that's a really humbling and good thing. So this diagram here, this is really putting it together a little bit, and the next one coming up as well, we're just talking about there's certain good things we need that are missing. And then there are certain bad things that we don't want in there. And there's a whole lot of stuff. But we're going to focus on the supplements and the foods. They drive our three things: mitochondria, inflammation, damage. That makes your nervous system fragile. And then we put in our neuromechanical part firing in, which then drives the same stuff. And the next slide is really the same thing, just in a different way.
Go back. Is this a bit woolly for Simon Billings, that we need love and connection?
You could argue that. I mean, I'm woolly on occasion. I mean, people need that. I think we're missing that in modern society. We're a bit atomized, aren't we? In our little houses.
It's psychosocial, isn't it? So there's a psycho.
Yeah, I think it's all. Yeah, I think we've kind of lost a bit of something, haven't we, in society? That's the same thing. I love a Venn diagram. Hands up. I just love Venns. I just love because this is everything I'm interested in is overlapping the nutritional world. When you overlap that stuff, and if you can get hold of these things, your treatment works that much better. But it's the same thing, really. The upper cervical 3, the trigeminal nerve, and all the stuff firing in, and then with our bits overlap there. All right. So the bit I'm going to talk about here is we need to try and break the vicious cycle somewhere. And the other bits, the bit that's circled, where it was new, the other bits are all the same. So we know that you might get foods causing inflammation, which causes mitochondria, causes neuroinflammation. That neuroinflammation might make your nerve sensitive, the trigeminal, and that can be primed by certain deficiencies. So like vitamin D will make you inflamed if you're low in it. That will mean you're more sensitive to your mechanical issues, so you're more likely to get pain, and that pain makes you more hypersensitive, and so you get a vicious cycle. But the bit at the top there is neurogenic inflammation, meaning your nerve is making inflammation. So you'll see this in complex regional pain syndrome, I believe, where neuroinflammation, it's your immune system is making the inflammation. Here, the nerve is angry, the trigeminal nerve, and out of the end of the nerve comes some substance P. And there's another thing here, which is a really big one, called calcitonin gene-related peptide, or CGRP to its friends. This is the one that we'll talk later, is the one that the drug companies are after, because it's an endpoint. So when your nerve gets so angry, trigeminal nerve gets so angry from all the things we've talked about, and it starts pushing out calcitonin gene-related peptide, it really then triggers something, and your body becomes overwhelmed, and that's the point at which you go into a full migraine.
So when you say the drug companies are after it, they're after adjusting it as an end point in research. What drug will cause it to change?
Yeah, we've got one, and I'll show you in a minute of that. Yeah, I'll show you that. Yeah. So that's the difference in this, because it's the central nervous system, rather than a lot of other stuff we talk about with healing of tissues and things. You get neurogenic inflammation. That's part of the issue. And then you get a trigger, and then we're over. And that's what I said, when you get past a certain point, you get increased release of this peptide, and it creates this, it's a spiral, and the brain can't cope. There's not enough antioxidants, not enough antioxidants, it goes poof, and that's the point. Then you get this sudden opening of the arteries, and that's going to stretch, which is a bit not like an ice cream headache. Not as bad, obviously. This is worse. And you get the capillaries become leaky, so you get edema around the brain. So there's a swelling and a fullness in the head, and this metabolic collapse, cortical spreading depression. The aftermath is the migraine. And we want to know, when we go through in a minute, where are we going to make our intervention? Where's the low-hanging fruit to pick from our research that we can go in there and make a difference? That's what we want to know. So this is the idea of like your bucket's full, and when the water spills over, you get a migraine. And this is the bit people tend to be obsessed with patients about their triggers, and they'll say things like, if I have chocolate or wine, I get a migraine. If I have it's bright light, or I get too much sleep or not enough sleep. But these things shouldn't give you migraine. They don't give me a migraine, and they're bespoke. So really what our bucket is full of, we have some genetic issues, we've got deficiencies, we've got food issues, and we've got our neuromechanical things. They fill your bucket, and then the triggers push you over. And what we want to do is get at the bits there that are filling the bucket, drain it out, and we'll see later on those triggers suddenly don't trigger you. And we've got some research to back that up. All right. So that's our misdiagnosis we mentioned. Let's just briefly cover that. I think hopefully this will be, most of us are happy with this. So the upper cervical facets, peripheral nerves, and maybe trigger point referral. The jaw itself and the temporalis. I find that very common in practice. The temporalis muscle, because we've got lots of changes in dentition, people lose vertical height, they lose teeth, they have crowns and something or the other. It affects the vertical height here, and the jaw tends to be protruded. And when it goes back a little bit and it impacts up, the anterior portion of temporalis goes into overdrive, trying to pull it forward. And because you see this, when I work with a dentist, if we put a splint in and we bring them forward, this muscle just goes so much less angry. It just immediately becomes less angry. So when it's say, my fellow got my head in a vice, it's almost always, in my experience, temporalis trigger points. And if we can work those and do some cranial work and stuff, that really makes a difference.
So other than splinting, what do you do on trigger points?
So that's one of the few places I do trigger points. I don't think trigger points do a lot in the longer term, but this is not a normal joint. You can't manipulate that. So I do the trigger points, and particularly you must get into the mouth and you must get your finger, the little finger, on the tendon as it attaches to the coronoid process of the mandible. You must get in there and get right, and it's exquisitely painful. People, it's like having a knife shoved in your face, and people often walk with that eye will water. That is really important to get hold of. Mobilize the jaw. Just check, we'll talk about dentition later on, and then also I think it's really important to do cranial work. I would do it internally. I don't think you do that in cranial osteopathy. I might be wrong, I might be craniosacral work, but I like to get right onto the wing of the pterygoid plate, and often because of the attachment of the pterygoid muscle, the lateral pterygoid, it's been relatively pulled down. That's the wing of the sphenoid. Lateral pterygoid is the wing of the sphenoid. It gets pulled down, and I think you need to give it push up along with pushing the palate up. So we would call that sphenomaxillary craniopathy. We would
Okay, I'm sure somebody who does a lot of cranial osteopathy will tell me if they do something similar or how they go about doing the same
Doing
thing.
internal cranial
osteopath.
Right, is much more powerful in my experience, because that you get much more leverage. And because of that pattern, like I said, with jaw issues because of teeth changes, is so common, that pattern is incredibly common. The other thing just to be aware of is if they had any fillings, they might get direct pain or an alteration of the occlusion. And then we said the infection, that's just is dead bone, and you have an infection in the bone often, and that can generate atypical facial pain. That's a Nico lesion, commonly misdiagnosed as atypical facial pain or atypical trigeminal neuralgia, because it often will go into the face as well, but that will then contribute to the potential priming of that system for migraines.
So how does it get diagnosed?
You go to a biological dentist, and there are not many around who either they can do it now with, I think they do these CT scans. You can get local CT scan, you can see it there definitely. If it's bad, they'll see it on an X-ray, or there is also a mini ultrasound called a Cavital machine, which picks it up as well.
So your bog standard dentist doing an X-ray won't notice it?
No, not interested. Not interested.
Is this just going to be one of your differentials here? Are there things which to you would say, no, you definitely need to be investigated for this?
Well, it would depend on the history and stuff, but for the most part, most of the time, it's the occlusion that's a bigger issue. And if we have time, we'll do a case study at the end. It's just looking at, vertical height changes in here. Sometimes, so a common pattern with jaw primary, which is causing part of your true migraine, or at least give you a misdiagnosis, will be they didn't used to have migraines until they got to 40 or 50. So if you've never had a migraine and suddenly you get them in your old age, you should be very suspicious their occlusion has been changed, and that slowly their system is compensating, the cranial is getting cranked down, that might be a driver, stuff like that.
Right.
But we'll come to that later, because I've got some slides about sort of clinical patterns that come up and stuff. Okay, so then we have our mixed pattern, and like we said, that's then they might be getting they might be getting a genuine cervicogenic or some kind of jaw pain, and it's firing into a system that is sensitive, and that firing in is part of which then triggers a true migraine, because the nervous system is delicate. And I'll just show you some research now. This is they're doing nerve blocks on the greater occipital nerve. So remember. if it's a true migraine, purely cellular thing, how much effect will this have? So it depends on the patient. So you see here on the green, where I've circled it in green, the intervention group, when they did a placebo and they did true intervention with the injections, it went in the intervention group at the end 6 days a month versus 19 in the placebo. So a massive improvement, right? So in that scenario, they must have some issues with the upper cervicals, and at the very least, that's contributing to true migraine, and or there might be that some of the people in the quote chronic migraine are in fact misdiagnosed as just this nerve locally causing pain, and it isn't actually a true migraine. But you see there's also in the second study I've circled in red, there's no difference between the groups. So in those groups, I suspect they're primarily true cellular migraine, and those group had less to do with the neck. It wasn't really involved.
Did you look into these in detail? Did you look at how they selected their samples, what the criteria were?
I might have done at the time, but I can't remember off the top of my head. I think again that might be the issue with. That's why if you look at again the studies, some of them are brilliant, some no change. And I think it might be it might just be the misdiagnosis.
And also the sample sizes are very small.
Yes, they're relatively small. Yeah, it's quite a lot of them accumulated, but you might be right, they're relatively small. So that's why I said, again, I think there's a mixed response there. Yeah. And it's the same here with a splint using for grinding in the day, and they have chronic migraine. And you can see here, it's only intensity of pain over time, but rather than days of headache, but it drops massively within a week. I mean, it's a huge drop. And then it carries on going. They took the splint out at 90 days. But again, in these people, clearly, at the very least, the jaw is either giving them a headache and or it's feeding into that system, because the trigeminal nerve, which we feel the pain through, is receiving information from all these muscles and from the jaw and from the teeth.
So I prefer the term splint to a posterior interocclusal device, which is what that slide said, isn't it?
Yeah, splint is easier. Yeah. Okay. So then we want to get now into the cellular bit, and the idea of being primed. Like you've got a smouldering fire in there, and what's going to spark it into a flame, and the triggers and so on. So just a little bit of techie stuff here. So when they talk about reactive oxygen species, it's just posh talk for free radical. So here they're talking about, we know that an accumulation of reactive oxygen species might be the trigger, primary trigger for cortical spreading depression. And then I just put this in because, just again to say, I just typed migraine mitochondria in, and you cannot move for research. I mean, it's just bloody everywhere. It's pretty well established that at the very least, this is a key driver, and because of you have to make energy, and your brain is really hungry for energy.
There is always the question of which is the chicken and which is the egg, though.
Yes. Well, I mean, the mitochondria are going wrong because of deficiencies and toxins. When it really boils down to it, you're just a series of pathways and recycling. Okay. And you need a certain amount of good nutrients to run your system, and if you get toxins that get in the way, that's it. And so it doesn't matter whether it's migraines or, motor neurone or whatever, it's the same stuff. It's just depending on the severity and what's damaged. Yeah. So cortical spreading depression, this is well established in traumatic brain injury, in stroke and so on. And I'm just going to read these bits out because it's interesting hearing them talk here. So they say cortical spreading depression can explain the aura of migraines, and it says it occurs when the cerebral cortex is stimulated by chemical, so that might be an inflammatory cytokine, it might be that calcitonin gene-related peptide, it might be glutamate, it might get MSG headache, monosodium glutamate, or it could be homocysteine, which is a toxic chemical we'll talk about in a minute. Or it can be an electrical signal. So that might be your neck and your jaw and your teeth firing into a sensitive system. That leads to excitation of the brain, and that's followed by an extended period of depolarization that spreads throughout the cortex. And that's that wave that people talk about of pain that comes down, this kind of crushing thing. And then they get initial increased volume, the arteries stretch, and you feel pain, and then they constrict after that. And that is well established, and we now know that occurs in patients with migraine very nicely.
Here's a weird question. Even I think this is a weird question. There's a lot of chat, isn't there, in pain research circles, that if you explain how people's pain is happening, particularly when it comes to spinal pain, it will help to reduce their response, their sensitivity to that pain. It doesn't strike me, this isn't a question, it's a statement, it doesn't strike me that that would work in these cases. Does it help to explain all this stuff to a patient?
I don't think explaining it is going to change anything, unless they're particularly stressed about it and paranoid they've got a brain tumor or something. We mentioned it in the stuff we talked about neuroinflammation and the biopsychosocial model. Yeah. Neuroinflammation, we're talking about here, underpins chronic pain because the nervous system is hypersensitive to incoming signals. It underpins nasty mental health issues, particularly when they're really resistant, quoted antidepressant tablets, and it will underpin fatigue. And you put them in the biopsychosocial model, they're all they're in pain because they're depressed and blah 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 blah. But actually, again, the root cause of a lot of these patients, like fibromyalgia, is they're inflamed and their mitochondria don't work. So while I've used this as an explanation for migraine, it underpins, like I said, everything almost without exception. Yeah. So if you improve these bits, people tend to improve. So when I treat one-to-one clients, there's a common theme throughout all of it. Yeah. If you get the right nutrients in, you can fill that nutrient gap, change the diet, like that, things will improve. Yeah. While I'm sure that can be helpful in some cases for sure, and I'm sure it does, I think it's very easy for the medical profession to say, well, you've got this back pain and we've done an X-ray and it's fine, so there's nothing there, so it's all in your head. And we know we know that sometimes it is in their back and they need treatment. And then sometimes, maybe they are hypersensitive because they're inflamed. And that's when the nutrition comes in. It's not that hard. Once you get the basic principles of this, and so it's not that hard. It really isn't. And it's common stuff. 80% of the time, it's the same 20% of information.
Yeah, and again, I don't want to divert into to laser, but while we were doing our laser training the other day, our Cat4 lasers, fibromyalgia responds well to lasers, and it's a mitochondrial effect, not a...
There you go. Yeah, exactly. Yeah.
So anyway, let's move on with this. I've got loads of questions, but I'm saving them.
So this is again, we talked about it causes this self-propagating wave of cellular depolarization. It's like a wave people talk about, which we've already mentioned that already. Okay, so we're now going to talk about calcitonin gene-related peptide, which is, remember, that's the molecule with the drug companies, they love it. So this is the final common pathway. It's potent dilator of the arteries. It makes the mast cells degranulate, so you get a sudden flux of histamine and inflammatory cytokine. That's why sometimes people will say, if I feel a migraine coming on, if I can get my medication, if I get some anti-inflammatories in, or sumatriptan, I can nip it in the bud. And that's because they've just managed to bring it back from the brink of that massive inflammation which is building and building, and they can just suppress it enough. Now remember that because this is calcitonin gene-related peptides being released from the nerve, that happens in response to neuroinflammation and nociception. So that's where, again, we can help with the nociception part, and then the brain inflammation, we can do nutrients, we can do that.
How many people are talking about CGRP? Because I don't know that I've ever heard of it other than
the drug companies.
So, okay.
Yeah, they love it.
Yeah. Can I need to clarify one thing for one of our viewers at least. Sarah says, are you talking more about trigeminal neuralgia than migraines? Because she's confused.
No. So remember that the brain depolarizes and you get this sudden, squeezing of the arteries, edema in the brain. Remember that the trigeminal nerve supplies the dura and all thing around. So the pain isn't brain sensitive, but the dura is very, 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 hence why meningitis, they get a bloody grey headache. So we're absolutely talking about migraine, and trigeminal is the nerve that the migraine is felt through. Right. Because the brain is really inflamed, and all that dura and the nerve, all the blood vessels are that feeling, and the aftermath is wild hypersensitivity.
Sure, but I can see why Sarah was asking that, because you talked a lot about the trigeminal nerve, and we are talking about migraines.
Yeah. So just as a quick summary here, this is a summary of a lot of research. So the calcitonin gene-related peptide, we know definitely it's higher in chronic migraine sufferers than controls, particularly it goes up during migraine. We know that you can induce a migraine experimentally by infusing patients with calcitonin gene-related peptide, but not in controls, meaning you have to be primed. So you can inject me and you with it, and we wouldn't get a headache. Right. We would feel fullness in the head, but you wouldn't get a migraine, okay? We also know that it's very pro-inflammatory, and we have good evidence that if you block it, it improves migraines, which we'll talk about now. And this is, I just put this in because it makes me laugh, because miracle medication, miracle drug. I'll give you one guess who wrote that headline and handed it to the news outlets. That's a press release for the drug companies. It's only $7,000 a year, $6,900, an absolute bargain. Let's now look at the results. And we're going to consider these we'll talk about our supplements. So in the treatment group, they went from nearly 9 days to about 5 days.
Premonizumab.
Yes.
That's what we're talking about.
That's what we're talking about. Yeah. So that's about a 45%. So they're having about 9 days a month of headaches, and it went down to about 5. So that's a miracle as far as the drug companies are concerned. So 45% reduction. Let's remember that 45%. We move on to the supplements, and we'll see how we get on with our supplements, okay? Note also that the placebo also dropped. They got nearly about 2.8 days worth of reduction. So not a bad placebo response either on that, all right? So we mentioned this earlier, we know it's underpinned by all those problems, inflammation, mitochondria, and so on. And can we ethically leave that place? We could squash calcitonin gene-related peptide for 7,000 a year, and they would improve by 50%. But we know that they are really way more likely to develop all sorts of nasty things that are going on. And I would suggest that is wildly unethical. Given that the research is so clear about that, I personally feel you can't call yourself evidence-based if you're doing that. Can you call yourself patient-centered if you're doing that? I would argue not, personally.
Isn't the counter-argument to that would be used by those people who probably are more interested in the drug company's success? Yep. It's one thing to say the evidence shows that all those factors are part of it, but we have the evidence to show that we can intervene in these other areas?
Well, we're going to talk about that in a minute.
I thought we might.
Okay. So we'll just mention secondary triggers here. So we've got things like histamine, tyramine, nitrite sulfates, MSG. These are commonly mentioned by patients. So tyramine, so chocolate, red wine, aged foods. Nitrites and sulfites are food preservatives, generally speaking. And then the MSG, the G stands for glutamate. Mm-hmm. Now, it's important to understand that glutamate is your primary excitatory neurotransmitter. So it's very important. So glutamate then becomes your primary inhibitory neurotransmitter called GABA. So it's like a yin and yang. That conversion is 100% B6 dependent. It's very important. So B6 deficiency is very common, particularly in certain subgroups like women taking the pill. It is almost universal. It's very, very common. And people who are very inflamed.
Interesting. And the NICE guidelines specifically address women who are on the contraceptive pill. And it says if they're getting migraines or other headaches, try them on this other drug.
Obviously. Why wouldn't you? Take another drug. So that's important. We'll talk about B6 later because that's really important. So just to let you know, like glutamate and GABA, they are, I think, at least 50% of your neurotransmitters are one of those two. They way outstrip in terms of number, serotonin, dopamine, all that. They're the dominant ones. Yeah. And a lot of your pain medication is based around blocking glutamate. So for example, pregabalin and gabapentin originally were thought to be GABA agonists, but they're actually antagonists to glutamate. Right. So if you can improve your glutamate status, you can do a lot of good. And what we'll find is that the natural endogenous blocker of glutamate is magnesium. Okay. That's why magnesium is good for muscle tension. It's good for nerve pain. It's good to relax you before bed. Because it blocks glutamate from getting at the receptor. All right? Yep. So if you can combine magnesium and vitamin B6, it's a beautiful thing. And we'll talk about that later. All right, that's why people occasionally get a Chinese food takeaway headache, an MSG headache, is because they've shoved a lot of glutamate in, they're on the edge, too much glutamate, boof, it tips you over and you get a migraine. All right? So these aren't really big things. The reality is that your bucket's full. And I would argue that the bucket is partly because of food intolerance or food sensitivity. So we have foods that contain nitrites and sulfites and so on. But I think a bigger thing is a food reaction because your immune system takes aim at that and says, I think you're a foreign invader, I'm going to attack you. And that creates inflammation throughout the body. And the biggest 5 foods, I've done a lot of blood testing. Gluten all day long. Half the population carry a gene for a gluten reaction. Dairy of all types, but particularly cow's milk. Eggs, nuts of all kinds. And then the problem is if you remove dairy, people go for nut milk. If you remove nuts, they go for soya sometimes. And soya, while it isn't eaten a lot, it is very reactive. So those are the big 5 foods that we often look at. So just a clinical point here, if you start mentioning foods to migraine patients, they'll always go, I've tried that. And what they mean is, I've heard that chocolate gives you a headache or red wine, so I've removed some of these things. And it's all based around the nitrite, sulfites, and all amines, all those kinds of things. So what we need to do is be very specific and ask, did you do it individually, which doesn't really work, because if you've got more than one thing, it won't give you a response. You must do all of them at once. And then, did they do it 100%? Okay, and really be specific. Often, they have not removed foods based on a food sensitivity, which we talk about there with gluten, dairy, eggs, nuts, and so on. That's the one that is more important in my experience. So sometimes they're a little bit negative about food. I've tried all that, doesn't work. You've got to then pick into what did you actually do What did you remove, for how long, and did you all at once? Be really picky about it. So this is a little bit of research, and you find a lot of the research on migraine food is old because the drug companies have got bugger all interest when they can push out a drug for $7 grand a year. This is 1983. So this was children with severe migraines, and they just gave them 1 meat, 1 fruit, 1 veg, 1 carb, done. And they had 93% at the end of the month had recovered from severe migraines. So that's pretty awesome, right? And that doesn't cost anything. All they've done is taken foods out that might be an issue, and they've got 93% response. I think it's so easily done, right?
What does that mean? 1 meat, 1 fruit, 1 veg, 1 carb.
You pick a meat, lamb, beef, whatever. You pick a fruit, pears. You might have 1 veg, whatever, and then 1 carb, whatever you want to have.
Okay.
Done. And then
whatever quantity you want it.
Yeah, whatever you want. Yeah.
Okay.
It's an elimination diet, really, at the end of the day, isn't it? So I just thought we talked about associations or comorbidities. Patients, so before, they had all these like abdominal pain, diarrhea, flatulence. So that's your GI system and your immune system really screaming, something is irritating me and I'm having a go at it. Behavioral problems, fits, runny nose, mouth ulcers, all these asthma and eczema, these are all just inflammatory things in different tissues. Before the diet, and then you see after, from 61 to 8, 44 down to 5, the fits from 14 of them down to 2 of them. Massive reduction in their quote comorbidities or associated symptoms have dropped. So we got rid of the cause of their migraine, or at least a big chunk of it, which is inflammation. Yeah. And then at the same time, we've improved. They've no longer having fits. They no longer have asthma.
You really piqued my interest there. That out of 88. Participants, 14 were getting fits with these headaches.
So again, because now you begin to understand what underpins all this stuff. So if you have asthma, what is asthma? It's just inflammation in the airways. Now, I know there's other things to it, some breathing stuff and mouth breathing stuff, but again, eczema is inflammation of the skin. What is IBS? That's inflammation in your gut primarily. Why is it there? Well, food is at least one thing, and maybe bacterial imbalance, a whole load of stuff. Fits, fitting is an excitation of the brain, uncontrollable. There's a thing called B6 epilepsy. No B6, you build up glutamate because you can't convert to GABA, and you get so stimulated, whack, you get a load of fits. B6 epilepsy, it's a thing. In fact, they call often that when they can't control the fits with the epilepsy drugs, which again, almost all of them are blocking glutamate. They're getting at their site. That's why if you get in the way of glutamate, you do reduce the fits down, but it really flattens people. Their energy vitality just goes right down because you've taken away most of their excitatory neurotransmitters. They've got no oomph. They're very flat.
So would you, as a general rule, say to someone who owns up to being epileptic, have you tried adding some B6 in and just...
I don't know about owns up to being epileptic, it seems like...
Well, some people don't like to admit
Is that right? Okay, I thought about that.
Some people don't like to admit to it, and I'm not suggesting that all our patients hide their medical history from us, but we know that a lot of them won't tell us things that they don't think are relevant.
Yeah, right. So in terms of that, epilepsy is important, obviously, so we don't want anyone stopping the medication without anything to do with the drug, but in those cases, absolutely, I'll say to them, listen, your drug, I write glutamate, what I write is excite. Here's a brain chemical that excites your brain, and I do a line and make chill. And then I say, that's called glutamate, and that's real name is GABA. And to get from here to here is B6. You have too much excitey stuff going on, and your drug blocks excitey from hitting the receptor, okay? So I want to give you a natural blocker for excitey, and that's magnesium. And I want to give you B6, and I have a product that has both in, and you take that 3 times a day. Does that sound okay? You might get more energy as well, and it might improve your mood, calm you down a bit. And so I'm trying to improve their lot, because what you might also find is that a lot of the drugs, ironically, deplete B vitamins. So lamotrigine, which is a common drug for epilepsy, will deplete B6 and other B vitamins. So you start on the drug, it works really well, and then you deplete B6, and then the drug doesn't start working, so you have to up your drug because you need B6 has dropped. And this is where I think just knowing a little bit of nutrition really adds value. And you can get in there and say, I'm going to give you these nutrients to support and help your drug work better. It might mean you don't have to keep upping your drugs. It might mean if you really do well and you feel better, you might be able to talk later on to your doctor about reducing your meds if you're doing really, really well in a year or two, whatever. And so and again, the inflammation thing, I should say the number one thing that makes your nervous system produce more glutamate, which remember then can build up if you haven't got B6, is inflammation. So inflammation makes your nervous system produce glutamate. So if you get the inflammation down by removing foods, all of a sudden the glutamate will drop, and that will improve all sorts of stuff.
Right. And have you ever had any kickback from any conventional medics who are saying, what are you doing talking about these things? I've got a drug that deals with this and you're interfering?
No. No. I mean, I don't know how much my patients talk to their doctors about what I'm doing. If, so no is the answer. I've never had any complaints or anything yet. And again, what I'm saying is it's all factually correct. I'm not telling them to stop taking the drug. I'm explaining the neurotransmitter and everything, which they have never been explained before. And I think it's very useful to understand that you are just a series of pathways in recycling.
I'm guessing, though, that they might raise the possibility that, I'm prescribing this particular regime of medicines for your patient. We don't know what the interactions are with the stuff that you're telling them to take. Now, I imagine your response will be, they're bloody vitamins, for crying out loud.
Yeah.
They're naturally occurring things which we know we need, so there can't be any interactions.
Yeah, because you get it from food. It's just that we're leveraging modern stuff to increase the doses to get it in people. Because, the reality is people's diets is crap. I'd love all my patients to eat an organic, grass-fed meat with, organic vegetables and this and the other. The reality is when you're really ill, it's hard and you've got to break the cycle, and supplements is usually the easiest way. These are the foods that came up in that. I just want to flag up again, we talked about gluten, dairy, egg, nuts, seeds and so on. If you look at the top food there on the far left is cow's milk. That's dairy. Then egg. Then there's chocolate. Now the chocolate might be, because it's milk chocolate, so it might in fact be the dairy, or it could be the tyramine. I suspect it would be a bit of both.
I was just trying to make sense of this. This is starting from here, going down
top
there,
down, and that's the number of people, number of children, in which when they removed all the foods, then you can't let that, you would then reintroduce them and say, which one causes a headache? Because some of these are going to trigger you into inflammation, which pushes you over the edge.
Basically, we've gone from most reactive all the way up there to least reactive at the running.
Exactly. And then you've got orange. Now, orange comes up now and again. That might be a reflection of the type. Like, this is in the 80s, and so that people were chugging, a lot of orange juice back then. Then there's wheat, which is gluten. Cheese again, look, that's dairy. Tomato, that might be because of a food reaction, but it might be also that tomato can release histamine. And then you've got rye, that's bread, as gluten again, and then a selection of other things that come down. But if you had gotten gluten and dairy and egg and nuts and soya, you would have had a good chunk of people's issues there. And then we'll talk from when we're using this study and other studies, we'll see things like peas come up sometimes and beans come up as well. You don't have to get every single one. So doing that elimination diet is quite hard. Getting a patient to go for four foods for a month is quite a big ask. So when we look at the research, and from what I've done with food testing, we can get 5 or 10 foods out and you'll usually get a response for the most part. All right. Okay, let's move on. And when we talked before about triggers and why would sunlight trigger a headache? Shouldn't do that. Here, you see, this is the number of you can't quite see the slide there. It says non-specific provokers of migraine. And you see before, on the diet, 13 people with exercise would have produced a headache.
Is it
on the
out
diet,
of 38?
Out of 38, yeah. So 13 to 38 found that before they did the diet, they would get a migraine could come on with exercise. And after diet, it's 1. So all of a sudden, we've drained the bucket, and that means that trigger, although it's pushing something up, is not enough to get you over and into a headache. And the same trauma, then again, emotional stuff no longer does it, and so on. So this is what I mean by, when they say, my triggers are, too much sunlight, too much sleep, not enough sleep, or whatever these things, they're not real things in the sense of they're not big issues. They're usually just a symptomatic expression of a system which is primed, and we're looking at why. And that's kind of what I mean there. The bucket's full on the left, secondary triggers push it. If we can drain the bucket down a little bit, you can't change the genes, but you can kind of work around them with some of the nutrients, get the supplements in, maybe go for the foods, and of course do our neuromechanical stuff. I think it's a really, really nice combination. And you can say, listen, and this is what one of the intake forms, I say, listen, you've got these migraines you come in with, but I'm just telling you, you've also told me you've got IBS and reflux, and you've got a bit of eczema, and you've had mental health issues. I'm telling you, all of those things are up for grabs through your food and diet. I'm telling you, they're all linked, very likely, not 100%, but very likely I can improve some of them by doing this with you. Would you be interested in that? Nice and easy.
Yeah. And how long does it take generally before before a patient will recognise the difference?
So we have got a slide coming up on that, but generally I will say to them we're going to do a month's trial. With foods, it depends how many migraines they're getting a month. If you're getting 1 or 2, you're going to have to do it for long enough to see that. Generally with food stuff, I'm doing food stuff for people that have got fibromyalgia and this, that and the other, or they've seen other chiropractors and osteopaths and nothing has worked. I then say exactly what I just said, that you've got all these other symptoms. They're all, I think, related to inflammation. We're going to do I would recommend you do a short, sharp food elimination, and I say 2 weeks for general stuff, because if you get the foods right and you get enough of the big ones out, within usually 2 to 5 days, something is very obvious. It's really obvious. They will just feel that much better. Energy, mood, aches and pains, or it improves pretty wildly. Yeah.
Now, I'm going to be very rude. One could be tempted to think that you are a single issue fanatic and that everywhere you look, you see it as being inflammation.
Yes.
And therefore,
that's true.
It's it's an opportunity to make people use supplements, and I didn't say flog them supplements, but I know that you can help them to get their supplements if they want to.
Well, I do flog them supplements. That is a fair thing to say. I'd run a supplement company, but yes.
Yeah. Okay. Well, I didn't want to say that, but I mean, presumably you do also find other things wrong with people, and you treat them in other ways as well.
Yeah, but absolutely. But you need to go for the stuff that's going to get them well.
And we are here to talk about migraines.
Well, yes, but I mean, in general, again, like I said, when you really boil it down, they have deficiencies of stuff. So yes, I could ask them, if I think they're low in magnesium, which is common, I could say, could you try and eat more fresh vegetables and nuts and seeds if I think they're going to tolerate them, and da. But the problem is that involves a whole load of hard work for some people. Some people are very hard, and they may or may not know me that well. So, but I know I can get the levels up by using supplements. Yeah. So it makes it very easy for them. And what I have found is if you're trying to make people do, removing food is easier. Just don't eat gluten and dairy, or whatever you think you can do, and that's quite easy, relatively speaking, okay? Than adding foods in, because there's less thought involved. Just remove that, eat some more meat, eat some more vegetables, eat some more fruit, have some honey, whatever, or gluten-free bread, whatever you need to do, right? So do that 2 weeks. So removing them is easy, and then the food with the supplements, you get to break the vicious cycle. That's what you got to do. A lot of people are very tired. You put a supplement in, like B vitamins and magnesium and D. Those 3 are commonly give multi with a high dose B built into it, mag and D. And I say, look, the chances, if you're low in this, you're going to feel better, a lot better, and within days, you'll notice something. It's very obvious. Yeah. So these will last you about a month, but I'm telling you, within days, probably you're going to feel something, if not, sooner. So once they get more energy, then they're more up for doing lifestyle change.
Right.
And then they go, right, now I'd like you to start trying to add some of these foods in. Maybe eat some liver once a week, if we can. Maybe I want to go and start some Pilates. I'd like to go for a walk at lunch from work. If you go in at the start, when they're knackered and they hurt and they're depressed, they're not going to do it. So therefore, at the beginning, you make it easy for them. You chuck some supplements in, you do some treatment, you maybe remove foods. Supplements first is what I do. If they're up for it, I'll get them to move the foods, do some treatment. Once they start to feel better with the treatment, they start to trust me a little bit more, and then I can give them more and more. I push the responsibility to them a little bit.
And it suits the modern psyche, doesn't it?
It's a pill.
Yeah, exactly.
It's a pill for an ill.
People want an intervention. Totally.
Themselves. Yeah.
Look, I know you've got other slides and other things to talk about. I've got a load of questions here, and we've only got 25 minutes left. So can I ask a few of these questions? And I have to say to the audience that if you want to get your question asked, the quickest way to do it is to hit on that video link, because as soon as we get one of those, we'll celebrate our first video question. I don't know what these, I haven't read through these, so excuse me for, they might be random. My mother, says John C., has suffered migraines for many years. She went on blood pressure tablets 6 months ago and hasn't had a single one since. Her blood pressure wasn't particularly high. In fact, for most of her life, it's been on the low side. She also has hypercholesterolemia. Any thoughts on this?
Not really. It doesn't really make a lot of, high blood pressure, even doesn't sound that high, doesn't really give you a migraine. It might be that she was, right on the edge, and that is something I don't know. It doesn't fit with anything particularly that I know about in terms of mechanisms or anything, so no.
Also, I'm intrigued by the hypercholesterolemia. Is this familial, or is this just the doctor has said you're a bit higher than we currently think is the optimum level for cholesterol?
That would be a very good shout.
And I would suggest she reads Malcolm Kendrick's books on the subject.
Yep. Yeah, exactly.
Malcolm Kendrick, The Great Cholesterol Con, and a number of other books, all of which are eminently readable. The latest one is The Plot Thickens. Yes, it's a lovely book. Great title as well. Grateful Mind says, I'd be interested to know if you have cross-referenced your diagnostic categories with the ICHD3.
Never heard of it.
International Classification of Headache I don't know, I'm making this up as I go along.
I'll have a look.
Yeah, okay, we'll do it. Smiler says, I've been told that there is a relationship between migraine and a reverse curve in the dorsal spine. Are you familiar with this mechanical cause, and are the sympathetic ganglia involved in this in some way?
I think, again, you just treat the patient as you find them, and you're going to look at the upper cervicals and the jaw, and of course you want to know why the upper cervicals are producing a problem, rather than just, it's quite tempting to give them a whack, isn't it? But I find they're usually compensatory to other stuff usually. So yeah, I can totally believe that.
Now, this is a question which I imagine we will come on to at the end. A few people who ask, is there a specific vitamin brand you would recommend, and the dosage for magnesium and B6?
Yes. Yes. Well, I run my own supplement company, so yeah, I developed a range because I've read the research about things like B6 and so on. And I ended up giving patients before that a lot of supplements, like a multi and then extra B and then this, and it got a bit out of hand, and it was reducing compliance. So then when we came to making the supplements, we could then build in all the stuff I knew I wanted, and particularly, this is really important, the doses you find in the research are often quite high. So for example, vitamin B6, commonly 50, 75, 100 milligrams of B6. The RDA is like 1 point something. So, but that's the research. So in things like PMS, they use 100 milligrams. That's what works. When you then go to use supplements, the supplement companies then will give you maybe a powder with some magnesium and some B vitamins, but they don't put in the effective dose because it costs more and it puts people off. So you end up not getting a response. So I have made it so that we can get those doses with a relatively small number of pills.
This is quite important, and I hope that people trust you on this and believe this, that you're not here to flog supplements, but naturally, as you've said, you've developed these because of what you found was going on. And again, I don't relate everything to personal experience, but quite a bit of it. I was doing what you described. I had one of those little plastic trays with 30 little canisters in it for my supplements, but to make me take them. I've still got it. I couldn't fit all the buggers in. They wouldn't fit in those plastic containers, which made taking them for me a lot more difficult. So.
Yes, exactly that. So
anyway, at the end of this, we will make sure people know where to go if they're interested in what you provide, and they can make their own decisions.
Yeah, and the supplements are specifically for basically neuromechanical practitioners. That's kind of the way I phrase, what we do is to support your treatment, and that was reflected in the dose of the B-vits and the magnesium. And you should always prescribe magnesium with B6. To get magnesium into the cell, you need B6. So that's where it links again. Magnesium blocks glutamate.
Do they? You go out and buy magnesium because someone says take magnesium.
Yeah, and you're not always low in B6, but the really chronic ones are, but with inflamed. So therefore, we've got magnesium with B6 built in, and you combine it with a multi, and that way your total B6 dose is like 85 milligrams. That's a therapeutic dose of the active form.
Right. Okay. Nikki says, can you tell us how do the triptan group of drugs work and why they're so effective in migraine relief?
So traditionally, they were thought to be a serotonin agonist, and there was some evidence to suggest that people with migraine had low serotonin levels. So there is 1 or 2 bits of research where people are being given 5-HTP, which is the precursor to serotonin. But when I dug into the research, thin would be an understatement. So the more recent research suggests that actually the triptans may well be an inhibitor of calcitonin gene-related peptide. So that's where you feel a bit of migraine coming on, you take a triptan, and they can work really well for some people. So probably they're calcitonin gene-related peptide inhibitors, nothing to do with serotonin, probably.
I find it fascinating that in many cases, and anaesthetics are a great instance of this, that medicine doesn't always care how these things work. If they work, then that's great. Yeah. And of course, from the patient's point of view, it is great if we can't find anything better to achieve the same end result.
I do occasionally give 5-HTP to migraine patients, but it's nowhere near the top of the list because there's so much other stuff there first.
Okay. I suspect I know who sent this one in, but I've been given no name. It says, chocolate, dairy and soya. A keto vegetarian with migraines is buggered then.
That would be fair, yeah.
Well, Claire, my wife, is a vegetarian. I suspect she's the one who sent that particular observation in. And I keep telling her just to stop being a vegetarian. That's the answer.
I would agree with that statement,
Ayala. Apologies if I pronounced that name incorrectly, I beg your pardon. Where would you send patients for blood, gut, allergy testing to see if certain deficiencies or imbalances are present to indicate migraine?
It's quite a tricky question, that. So, because in a chiropractic setting, I don't really, because I treat empirically. So we'll come on to that. Well, I'll go over the supplement stuff, which coming up is not that long. It's quite easy to do, and we'll go over it. Yeah, okay. There are common themes, and like I said, we know that common things are common, and they produce certain things. So I treat empirically, and then I might occasionally run an organic acid test, but you'd need a bit of training in that. Mm-hmm. So because blood testing for certain things isn't always reliable, because what's in the blood isn't what's in the cell, whereas organic acids, it's a reflection of intracellular use, but that's not any good for an average osteopathic chiro, I'm afraid. So the answer is I don't really do that very often these days.
I think in my show with Tracy Whitty, she did recommend a couple of labs for testing for B12 and talked about...
she's probably talking about methylmalonic acid and homocysteine, I think is probably what she mentioned.
She did, yes, yeah. But of course that was very specific to B12 in her case. And she talked about false results, as you did earlier.
Exactly that.
Misleading results. Jan says, I've suffered from migraines my whole adult life. After being diagnosed later as an adult with type 1 diabetes, I find if my blood glucose gets too low, I get the classic visual disturbances and then a migraine. Why is that?
I almost say because it's very stressful for your system. Your sugar levels are dropping through the floor. Your brain is really, dependent on that, and that's sensitive. And it's probably just very, very stressful for your system. Yeah. So again, if she can then do some food elimination diet, do some supplements, play around with it a little bit, she may find that then she's less sensitive to those changes.
Okay, something for Jan. SG says, I'm interested in menopausal migraine as I never had them before menopause.
Yep, so again, with that, it might be that you've had a very bad menopause and you've got a relative loss of, the most common pattern in menopause is not enough progesterone, and you've got your estrogen, which must be broken down in the liver, comes out in still a slightly active metabolite form, which is then still effectively working as an estrogen, and you get an estrogen dominance relative to progesterone. Women, particularly when they've had lots of PMS, PMT, and breast cysts and other things, when they go through the menopause, it's bad. So it might be it's a very bad menopause and she needs to do some work around her hormones. But again, it might be that her bucket was relatively full and that she's had a change in the migraine in menopause, and that she does the basic work that might be enough to allow her to get through that. So I would always do the basic work first, because it's quick again, and removing foods doesn't cost you anything. Handful of supplements, and for a month, I always recommend a month's trial on supplements. You'll see in some of the research coming in a minute, most of the studies last 3 months, but the bulk of the change often happens in the first month. So a month's trial is always warranted, and then I would do that, and then you might look at your liver health and maybe have your progesterone and estrogen levels measured.
Okay. Is your wife called Lucy?
No.
Yeah, that's interesting because Lucy's a big fan, obviously.
Great.
Lucy says, I love his supplements. Makes it so easy to take meaningful doses in one multivitamin. It's the only one I've ever found that doesn't make me feel nauseous as well. So thank you for making them.
She's very welcome.
So you have a fan.
There you go. And they're clean label. So there's just the nutrients in there, and then any space, we just put a little bit of rice flour. Done. No, nothing other weird and wonderful in there.
Mary says, any thoughts on infrared therapy for vitamin D production?
You won't get any with infrared. It's UVB or nothing. I'm afraid she's misunderstood that. UVB lamp will do it. I have one at home, or you can go have a sunbed, or you get natural sun between April and about September, between 11 and 3. Otherwise, you get nothing.
Yeah, okay. Salome, now we're getting back to the case history that you talked about. We've got 10 minutes left. Salome Olivia says, what's your approach for patients who present with an acute attack of migraine in the clinic?
That never happens. They don't come in with an acute migraine. I've never seen it. They don't come to me with an acute headache. They lie in a dark room. Yeah, that's what occurred to me. I wonder if Salome Olivia means someone who's in your clinic and gets a migraine. Let's hope it wasn't after adjustment to the upper cervical in case it's a stroke. I honestly, I wouldn't know. I'd probably tell them to take some anti-inflammatories and just keep my fingers crossed that it knocked it off. Yeah. Okay. Well, maybe some others have some ideas on that, but of course, what can you do when someone's in that state of distress? I don't want them hanging around a clinic if they're having a migraine. Yeah. And Vlad says, I thought that pill-based B12 is not enough to supplement with, and you can only do it with injections. And again, that's one for I think the B12 video, the show that I did with Tracy, goes into that in quite some depth. Sublingual works very, very nicely. I've got done before and after tests. They work fine. I've done hundreds and hundreds of patients, and also liposomal can also work as well as an injection. Yes. I had ladies who were injecting themselves coming in for treatment. I said, just try the liposomal, and they discontinued injections completely. Okay. All right. Did you want to move on to? Yeah, let's move on, because there's not that much to go through, I don't think. It's just, I want to go through the supplements bit, and you'll see the changes with that. Okay. All right. Okay, so the food thing I just mentioned. So when you're talking to patients, if they say, oh, I've got food that trigger me, just double check they're avoiding it 100%, because occasionally they'll say things like, well, I avoid it as much as I can. That means nothing. You've got to pin them down and say, how often do you eat in food X, Y, Z? I want to know, and they'll often be eating it in low amounts, still triggering themselves. So weird as it sounds, even though they know X, Y causes a migraine, they're still eating it. So that has to go. And then the protocol would be move any known triggers, and then on top of that, the big 5 foods: gluten, dairy, eggs, nuts, soya. And then if they're up for it, I would go corn, peas, citrus fruit, tea, coffee, chocolate, beans, yeast. And that would do that. You can do a blood test, but honestly, I've done so many blood tests, the same sodding foods come up again and again and again in some combination. Save yourself 250 quid and just do those big 5, and if you can up for it, the other ones as well. And just say, look, it is a pain in the arse, I get that. You've come in with these things. I'm going to say, look, you can, it is a ball ache, but suck it up for a month, see how you get on, and we'll go from there. You can always stop if it becomes, a thing. All right? Okay, supplementation. So that's the supplement. That's my company. So level 1. So within the protocol that I have in the course, there's different levels. I'm not going to do level 2 because I want to keep it simple. But you go broad spec, multi-nutrient, but you need very high B vitamins within that. Okay, for a reason we'll talk about in a minute. Then you need to complement that with magnesium, and that needs the extra. That's the magnesium plus that has B6 built into it, so you can double up on the B6. You need a dab of vitamin D. And you want some K2 in there as well, particularly MK4 form is important, not just MK7. And then the other bit is you want some riboflavin. So there's 50 milligrams in the multi, which is a high dose, but in the research studies, they use 400. So you need to add on another 350. And then I would add in some CoQ10, which is critical for mitochondrial function, at 200 milligrams, okay? Statins block CoQ10. So if you get patients with horrendous muscle pain, aches and pains, it's because of CoQ10. Or statins also, because they stop the production of cholesterol, your vitamin D is made from cholesterol. So sometimes they've dropped your vitamin D down, and that produces a pro-inflammatory state as well.
So you've got Malcolm Kendrick on the show with you, actually. We can talk about statins and
oh God, yeah, he's good. I love a bit of Malcolm Kendrick.
Yeah. So hang on, how many bloody pills is this lot?
That would be one, two. Well, it depends on the size of the thing. So it might be 5 or 6. 1, 2, 3. The vitamin D is sublingual, so you just suck it like a sweetie. That increases the absorption. It gets around. I had a guy with Crohn. You can get all the nutrients in through the mouth if you just let it absorb. Yeah, it's going to be a handful, probably 5 or 6, maybe 7. And again, you just say it's a month trial, see how we get on. And then as I've drawn a line there, underneath the line it says acetylcarnitine and B12. This depends on the patient. If they're up for it, and you want to go for it, then I'd add those 2 in as well. Carnitine is a shuttle to get fat from the cell into the mitochondria. So if you're on a keto diet or high fat, you must take carnitine. And B12, we know it has a really important place in the Krebs cycle. All right, carnitine is brilliant for depression. It's also brilliant for fibromyalgia because it improves mitochondrial function. You get more energy, and that improves it. So I go for, that's my opening level 1 is those 3 plus extra B2 and CoQ10. That's a good level. If you want to up it, then you go for the carnitine and B12, and then the foods underneath that, we go for the foods we talked about just a moment ago. All right.
And is this specifically for migraines, or would this be a sort of a general regimen for anybody who's getting aches, pains, IBS?
Those 3 would be all my chronic patients. They have to go on those because they're buggered. The B2 and the CoQ10, that's specific to migraine because the mitochondria has, and we've got good research in that, and we'll talk about that in a second. So magnesium, this is a common one people know about. We know that serum magnesium is an independent risk factor for migraine, and that they have lower levels and so on. And we've got a few RCTs with a good reduction. You see here. The only thing here is they listed migraines per month rather than headache days. So 3 migraines a month might actually be 9 days of headaches or whatever. So it looks 3 to 2. It doesn't, but of course it's a relative thing. But anyway, a 50% drop, and the intensity also 50%, which is pretty much what we got in the drug study, albeit they've talked about it in a slightly different way. And then CoQ10, again, it improves mitochondrial function, it improves energy, and we know that for sure. If you take a statin, it can completely cripple people. And we've got 4 RCTs, and I'll give you a little sample there. Top one, that's a 27% reduction relative to placebo. The bottom one there, quite over 75% reduction. So there was 8 headache days a month, which is similar to what I had in the drug group, down to less than 2, which is bigger than the drug. Quite a big placebo response there, but if you note on the second bit here, that's the severity of the attacks. There wasn't that big a change in the placebo group, but there was again with the CoQ10. So again, easy, low-hanging fruit to pick for that stuff. Vitamin D, again, is just pro-inflammatory, and it's so common. And you see here, averaging...
Vitamin D deficiency is
it's so common. In the middle of winter, it's about 87%. And
sorry, you just said vitamin D is pro-inflammatory.
So if you're low in it, you produce inflammation, Well, that's the why it produces stuff. So over 50% reduction in frequency and number of days and intensity. And also, look, it reduced CGRP because it reduces inflammation in the brain, and therefore it reduces the production of CGRP. I'll show you a study of that in a minute. And then we get to the B vitamins and homocysteine. Now, little teeny bit of here. So this is called methylation, which is incredibly complicated. We make it nice and simple. You take a piece of protein, amino acid called methionine, and you take the methyl group and you make stuff. And you make really important stuff. Myelin, pretty important. DNA. Your neurotransmitters get turned on and off. So it's a way of making stuff and breaking stuff down. It happens millions of times a second. Then once you've done that, you get homocysteine as an intermediary. You must then remethylate it, and you do that by taking the methyl from methylfolate, which is the active folate, and you give it back, as long as you've got enough B12. The enzyme is B12 dependent, so those come together and you get methionine again. Or you take B6 and you shut it down and you make other stuff. Brilliant. The problem is that homocysteine is incredibly pro-inflammatory. It pretends to be glutamate and it hits the receptor. So it's neuroexcitatory. It is a known modifiable risk factor for dementia. Fact. Right. Drug companies do not like that and have put out some really crappy research to try and water down the good stuff. But it's definitely an issue. And it's a trigger of a hyperexcitable nervous system. So think pain, and it also can produce osteoporosis and a whole lot of other stuff. And you just need B12, folate, B6, and it comes down very, very nicely. The genetic issues of migraine are around the ability to turn your folate on, and it's called MTHFR. And that's why if you have children people who have had headaches since they were a child, often there'll be a family history, and it's often underpinned by that issue. And you can get around that by using the high dose supplements, all right? But if you've got that gene, you can't make methylfolate very well. And this whole system grinds to a halt. And the drug companies, they patented the first methyl form of folate. They have a drug called Deplin, which is a high dose folate thing that they say this helps your drug work better for depression. What they're actually doing is removing the cause of the depression and giving a drug anyway. And it was Merck that patented and developed all this stuff originally. So B2, note here that we've got 9 meta-analyses. They're using 400 milligrams. Note the RDA is 1.4, okay? This will make your urine go very, 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 very yellow. It gets quite normal, it's okay. But if you look at the mechanisms, it's all through Krebs cycle, B2, and all the B vitamins really are at various points really important. And note CoQ10 is at the bottom there, and that HMG, statins are HMG reductase inhibitors, so they stop the conversion of HMG going to CoQ10. And the research here, this is one of the studies on B2, that is vitamin B2 against sodium valproate, which is quite a hardcore headache drug. And again, both work for nearly 6.5 days a month down to about 2.5.
And I'm guessing that the cost of B2 is considerably less.
Peanuts. It's peanuts, dirt cheap. So just a quick one, when we talk about patients with aura, like we said, they're more likely to be a pure cellular thing, often with really big deficiencies and food sensitivities, and respond well to that kind of thing. They often will have a bit less of the neuromechanical stuff contributing into that trigeminal cervical nucleus. So when they turn up with migraine with aura, they're typically at the far end of the spectrum having a pure, true migraine without necessarily having a neuromechanical input to that system, generally, I would say. And then patients without aura, they more commonly have a mixed pattern where they've got some deficiencies and some other stuff foods, but they've also got that neck and jaw feeding into the system, and they'll tend to respond slightly better to the neuromechanical stuff when you combine it with them. All right. And you see here, this is the vitamin D study we talked about with calcitonin G-rated peptides. So on the left there, patients with aura got a 43% drop in number of headaches per month. Patients without aura got a 32% drop. So still really good, but just the patients without aura didn't respond quite as well. All right? Yeah. Okay. That's what I said earlier. Patients who've never had a headache as a child, never had a headache in younger adulthood, and then when they're 40 or 50 suddenly get a headache, just be aware they may lack the genetic predisposition through that methylation stuff. They might respond a bit less well. And the things we want to be aware of is a deficiency but driven through medication. So maybe they've become diabetic, they're on metformin, and metformin blocks the absorption of B12, and that grinds your Krebs cycle to a halt, which then makes more homocysteine and you start getting migraines. Maybe they're on statin. Maybe they eat fish every day because they've gone pescatarian and they're eating too much tuna and they're full of mercury. You know, there's something, might be something going on that wasn't there before, and have a really good look at their teeth. Have they had crowns put in? They lost a few teeth. Have they got the dentures in that are old? These things might contribute to a wonky jaw that then triggers more stuff, and that then is a big shift in a change. And or it might be that if they're getting, quote, migraines, it's not a true migraine. Again, it's really important to pin them down, all right? So the general protocol that I go through is I really screen the history personally, look at colic as a baby, migraine as a child, abdominal migraine, and then cyclical vomiting syndrome is just migraine with a different thing. Look for mental health issues. That's associated with neuroinflammation. Look for insomnia, often neuroinflammation. Are they vegetarian, vegan? So there's a relatively, it's harder to get high levels of nutrients in that group. Look for tummy stuff, so IBS, inflammatory bowel, reflux, anything like that, because again, might be a chance of, you know, of inflammation in the gut, which is foods, fibromyalgia, and then jaw stuff, and any head and neck trauma that might increase the risk of peripheral nerve entrapments. Look at the family history for migraine, and then if they have methylation issues or inflammatory genes, they'll often have early onset or high frequency of dementia, stroke, heart attacks, osteoporosis, and cancer. So if everyone's dying early of certain things, that should be as a genetic component. Strong history of mental health issues, history of relatives having B12 injections, or other bowel diseases, and then the meds. So statins for CoQ10, proton pump inhibitors are a real bugger because they're so commonly given out, and they slowly reduce your ability to absorb minerals and protein, and they lead to infections in the gut as well. Metformin blocks B12, and then we talked about triptans. Like I said, traditionally triptans are thought to be serotonin agonists. We're not entirely sure if they are or not, so I don't use that as it's not a very, what's the word? It doesn't consistently give me results, so I'm very selective in what I do with that. All right?
We've overrun already.
Oh, right, goodness.
I'll leave it to you. Are there more important slides here?
I think we've got most of it done, yeah. This bit is good. So the top left bit there, we screen the stuff, then we look at their symptoms, really dig in. Is it proper migraine, is it not? Then do the exam, look at their neck and their jaw, and I would just flag up this stuff here. So loss of molars, or missing one molar where the tooth has then fallen in and it changes the occlusion. Flats, where they lose the vertical height of the back and they get flat across the front, or very, very old dentures. Often the old worn down dentures, they have incredible neck tension. All you got to do is stick dental rolls on the back molars, disocclude them, and then get to walk around the room, swallow a little bit, and then sit down and then check all your findings. And if the jaw is a big issue, it will massively improve. It's called the Mersmann test. And I think that's everything.
It's enough for now.
Done.
Do you know, Simon, thank you for all that. And I let it run over because there's so much information in there.
Yeah, it is quite a heavy.
There was some chat been going on about, oh, this is a sales pitch and whatever else. And I think I'd have to challenge the audience and say, where am I going to get somebody who's got your level of knowledge about the nutritional deficiency that you've described here, if they don't have a keen interest in supplementation in one form or another. Now, there's no requirement for people to go and buy your supplements because you've told them what supplements they need.
Totally, you go and get them all yourself.
Get them anywhere they like. The fact that you do them in a convenient form is great, and if people want to use your stuff, then they can.
They're more than welcome.
Personally, I think there was an awful lot more science, research, and information in that than there was just selling supplements. And I think people, they must have learned a phenomenal amount from that.
It's all about breaking the vicious cycle. And like I said, food removal is one way, supplementation is another.
Well, here's the thing. I mean, Sue here says, please stop, my brain's full. I mean, you just gave so much information.
Yeah,
and of
it's
course,
quite a heavy topic, isn't it?
We will put out the slides as handouts so people can refresh their memories through or research it more. I suspect that they can sign up to your newsletter and get more information from you that way. And again, we'll make all those resources available, but it's not compulsory. You don't have to do it. It's just,
I send a newsletter every Friday at 5. I send out latest research on a whole lot of stuff and a bit of clinical input, and it's there for you.
And somebody here, well, actually, it's my wife Claire again, says we should get Tracy Whitty back on the show again as well.
Tracy's excellent, isn't she?
Yeah, she is. She's lovely, and she's not a medical practitioner. She just knows a bloody lot about B12 deficiency.
Without a doubt.
Yeah. Anyway, Simon, brilliant. Thank you very much.
Absolute pleasure.
For joining us this evening. That's all we've got time for, as you can tell. I really hope you got some useful clinical tips from this show, and I'll send out the handouts, as I've said, with links to all Simon's resources, and it's up to you whether you use those or not. I'll probably do that tomorrow evening because, as I said, I'm on jury service, so I shan't be free until then to get it all done. Very quick look ahead, because I know we've overrun. As I said, because I'm on jury service, I can't be here for the lunchtime show on Thursday, which is why I'm handing over to my colleague Brooke, a fellow osteopath. She's going to be talking to Karen Grinter about Pilates-based stuff, rehab exercises that you can use in clinic. It'll be a great show if Karen's previous stuff is anything to go by.